Well, good afternoon, and thank you so much for joining us for a special edition of BurnCast on facial care. Today, we have our nurse practitioners, Ann Sorello and Liz Weibel, to talk to you all about faces and what to do and what not to do with them. Ann.
Thanks for the introduction. I think we'll get started by, I have a little PowerPoint presentation to kind of talk about just overall facial burn care. And then we can go into some Q&As or kind of just go with the flow. Liz has some examples of a few different things, so we can also do that. Let me start by sharing my screen.
Yes, thank you, Cindy, so much for having us. This is certainly something that that is very near and dear to our hearts. Facial burns are tough. Facial burns are tough because obviously a child's face is what everybody sees. Facial burns, as we'll go into in just a moment, require some pretty in-depth care at home, and they hurt. So hopefully this presentation will give you some tips for how to talk to families and really how to help them get through the initial acute phase of this injury.
And I think that when talking about facial burns, one of the things is that they're so striking because they're, your face is your first impression, your first presentation of a person almost is that you see their face. Whereas a lot of times if you have a shoulder, it could be covered up by a shirt or whatnot. So they're harder to bandage up or put dressings on, and they're very striking, but they heal remarkably well, which is usually reassuring, but the first few days to week can be really overwhelming for both the patients and the family and providers too. So we'll just start by going into the depths of burn injuries, just a refresher for everybody who either knows it or people who don't quite know the different depths of burn injuries. This is an example that I pulled off of the internet. You can see the link down there. Superficial thickness injuries are what we used to call first degree burns. Anything that does not blister. It is the epidermal layer and is kind of a sunburn, right? So you think of it as a typical sunburn. Partial thickness injuries are anything that blisters, and then this is broken down into superficial partial thickness and deep partial thickness. And you can kind of see the differences, like a wet pink blistering is a superficial partial thickness. And then if it's a little bit of a deeper injury, you can see that there's some hyperemia in that second picture of the hand. I think I can get you a pointer. So on this, you can see a little bit of hyperemia and some capillary bursts, and this is a little bit paler, whereas this superficial partial thickness is a pink injury. And then you go into full thickness, which is third degree and needs grafting. And you can see that this is just white and dry. Sometimes you get like a dark brown eschar as well. This also is really descriptive of how burns are not homogeneous. You can see a superficial partial thickness here, that really pink, probably, blanching if you were to touch it. Deep partial thickness has some of that hyperemia and capillary burst, and then right here is some white, drier, full thickness injury. And then another photo that I found that was kind of interesting, and I have, if anybody's wants to see examples, or we see this all the time in burn clinic, so we do have patients that we've seen, but this is again from the internet, and this is day 2, and you can see how between day 2 and day 5 both of these have converted, this deeper area has converted to a full thickness injury. So burns do change a lot, especially in the first few days, which is why it's important for us to take care of them as best as we can. Especially, as they're fresh and even more painful in the first few days. Should we move into kind of dressing changes and talk about that next?
Before we move on, I have a question about the assessment of facial burns.
Yeah.
So when we're talking about facial burns, is there a rule of thumb of like where it lands on the hairline of like face versus head? And is there something that we can have our nurses look out for, of like, we may not know the full like scope of the injury if it's going into the hair, and what to look for and what to be concerned about with that?
Absolutely. So that's a really good point, Cindy. If you think about the majority of the burn injuries we see, majority of these are in children who are less than 2. And if you think about how they're spill scald, so it's usually some type of hot coffee, hot tea, hot substance. And the usual mechanism we see is that a little one toddles over, pulls something hot from a counter onto them. So 9 times out of 10, burning the face, burning the shoulder, potentially chest, but more often than not, the face is involved. I always like to say, make sure you see a clear line of demarcation. So if the burn ends right here, maybe involves the cheek and the chin, then you're in good shape. But if you're close to the hairline, you always have to suspect that the injury extends into the hairline. So again, a really good assessment to make sure it doesn't go much further back. There's certainly more implications if there is involvement of the scalp, the injury.
And sometimes if that scalp is involved and it's a deep injury, we may even have to shave the hair to get an evaluation of how much is involved. Say, you think that you just have a small face burn, but it comes back and then it could even go further, have another couple percent TBSA into the hair as well. And that's when we have our most severe burns. And usually that happens in the operating room when we're doing some significant shaving. But that's a great question, Cindy.
Is hair shaved in the emergency department, or is that only in clinic or in the operating room?
We occasionally shave in the emergency department. We will do that under sedation. We will do that in the operating room. In clinic, I won't do much more than a little bit of a trim if it's just a small amount, because we don't have sedation in clinic. We have, pre-medications with oxycodone. And as you shave hair, kind of this skin and debris comes off with it as well, and it can be pretty painful. So yes, you're right. I mentioned OR, but also it can happen in the emergency department.
Mm-hmm. And just a quick plug here for clinic. We just want to make sure those visits are as quick as possible. So we really want to avoid extensive dressing changes, an extensive haircut, really anything too terribly involved or painful. Because again, the kids are going to have to continue to come to us for follow-up until the injury heals, which could be anywhere from 1 to 6 weeks.
So do you have any advice for the emergency department nurse that is concerned that the burn has crossed the hairline, but the providers assessing the burn are not concerned? Is there anything that a bedside nurse could say that would trigger a provider to be like, oh, I need to take a deeper look? Is there a specific way to say that?
Yeah, I think if, it depends on who. I guess just your question asking probably for the burn provider, because for a facial burn in the emergency department, our burn team should be involved. And
okay, so that's a great point for everybody to remember as well. That,
right.
For our, especially our ER nurses, to know that if you have a facial burn that needs to be debrided, we should be calling the burn team.
Yeah. And we often will remember to look into the hairline, but not always. And we have a number of different providers who come down. So I think there are probably a few different ways you could say it, but maybe, oh, it's really close to the hairline. Do you think that goes further back? Can I help you look further back? Or do you think that maybe goes further back? Or do we need to evaluate if it's in the scalp or something along those lines? May be helpful to kind of trigger that provider to, and you don't have to necessarily shave the head if you think that it's there. You got to give it a little bit of a scrub and look in, I'm going to mess up my hair here, but look in between and kind of really see if you can see if the skin's intact or if you have blistering there and if it needs a further evaluation or not.
Absolutely. And also, we just talked about how burn injuries evolve over a couple of days. If you're seeing a child a couple hours after the injury, I would make sure I'm telling the parents, hey, the scalp looks a little pink. I don't think it's terribly involved right now, but keep your eyes out for it. Keep your eyes, open for any signs of peeling or blistering. Because again, the injury can change over the first couple of days.
And I really like the way you said to have bedside nursing try to leave that subtle hint of can I help you look? It looks really close. I think that's really helpful. So,
and you can even take your gloved finger and kind of give it a little bit of rub and say, maybe that looks like it might be peeling here, or something along those lines, right?
Yeah, I think that's really helpful. I didn't mean to get us sidetracked off of faces, but I was like, the head is so close.
It's part of facial. It's the whole, we should call this head care instead of just facial care.
Head care.
Head burns. I don't know. I think it's definitely involved and under the same topic of care. Yeah.
Great.
We can move on. Okay, so this talks about just generally our facial burn care, facial and head burn care. The way that I like to think about it is those that have bandages or dressings and those that are open to air. And that might be one patient has both. So if it's just on a cheek, I'm not going to wrap up a patient's like half of their face, obstructing their nose or their mouth. So that's would be considered open to air. We would clean it. This is the bottom one. We would clean it at least twice a day and as needed. The most important thing is to get it clean and get all the old ointment off. Burns set out, a serous protein fluid that gets caked in with Aquaphor, which is what we usually use on facial burns. And you have this drainage, dead tissue, like old Aquaphor, it becomes this layers of crust if you don't clean it off and keep it. Your goal is to keep it kind of moist and clean. And then Liz, I don't know if you want to take over on the Xeroform, kind of how we wrap and keep bandages on the head or face.
Absolutely. So the first thing, let me just emphasize what Anne was saying. So when we talk about removing all drainage and dead skin and ointment to get a clean wound bed, so we can apply a thin layer of fresh ointment, there are a couple of different strategies that we use. Number one, we may advise that the parents soak with a small amount of a facial cleanser. It's called Vash. Soak the child's face for a good 5 to 10 minutes if it can be done. Again, we recognize these are toddlers. Again, most of our population is 2 and under, so this could be pretty tough, but perhaps it's applied while the child is sleeping. Or maybe the child's in the bathtub. You entice the child with a new toy, bubble bath, something like that, again, to get everything nice and moist so you can wipe that old cream, that old skin away. And you'll want to do it with a real firm pressure, if at all possible. Of course, we advise you administer, or the family administers, pain medication 30 minutes beforehand. But that's one strategy, having the child with a face that's soaked, and then the family can just kind of wipe everything away, create a clean wound bed, and then reapply that moisturizer. In terms of more extensive facial burns, so again, that would be for a small area, but for a more extensive facial burn, if we need more moisturizer, we may advise that something called Xeroform is used. It's a yellow impregnated gauze, and a strategy for that could, again, pretend this is the yellow gauze, could then be the Xeroform is applied to the face and then secured with something like a Curlex wrap around baby's head, around baby's chin. So I'm going to go ahead and work on that and show you what that looks like in just a moment.
It's helpful to have 2 people, one to hold the baby and one to do the wrap.
Absolutely. But again, I think it's also really important to remind families that, the skin on the face is very, very thin, so it's more easily injured. But in the same way, there's such a great blood supply that facial burns do heal relatively quickly, wouldn't you say, Anne?
Yeah, it's quite remarkable. It's very overwhelming for the first few days, and then they heal really quickly. A partial thickness facial burn can heal in 4 or 5 days.
Absolutely. And a lot of times I just say to the family, give it a week. It's going to be so much better. You're going to see progress every single day. Here is how I went ahead and wrapped the baby's head. Again, just a quick strategy. It doesn't have to be too tight, but even if it just supplies a few hours of moisture with the Xeroform, it can really help to soften the skin and all of that exudate up in the first few days.
So if we have a patient that is admitted on surgical care or in the PICU, and they get the order facial care, which I will say is most of the time every nurse's nightmare to see facial care twice a day, and you're like, oh geez, how are we going to do this? Some of my colleagues have said in the PICU have said that when they did facial care, well, first the Vosh that they were given was only available by the pharmacy, so that was hard. So I'd love to talk about like that whole process and how much to use. But they said that when they were doing the steps to like remove the dead skin and all that yuck, like that exudate, that they created bleeding, and that freaked them out. And it freaked the parent out that was at the bedside. It freaked out the nurse, and they thought that they had cleaned too much. Can you talk a little bit about that?
Certainly, yeah. So Bosch is helps. It's a chemical debrider. It's kind of works like the white blood cells in your body, in that it eats at debris and it debrides just by sitting there. I generally soak a 4x4, a couple 4x4s in Bosch, and I guess I don't want it dripping wet so that it's cooling down a patient's face, but I want it saturated enough that it's actually getting through. Maybe like a sponge, but if you wring it out, it's not going to just completely empty. I don't know if that helps describe it a little bit.
No, that helps, because you don't want it to be super saturated. You just want it
just enough to
just enough,
but not like a dab that doesn't actually wet the underlying kind of skin and thick. I actually think in the next one I have a picture. This is not a face burn, but similar to what can come up and look like if you have a lot of really thick crust. So you do want to kind of soak it a little bit with Bosch. When you're doing that, I think with the Bosch, use it for its strength, which is to sit on for 10 minutes if you can. I will even sometimes with a patient put Bosch on and wrap them up with some soaked gauzes, wherever it might be, and wrap them up and leave them for just like how she has that wrapped up, but instead of Xeroform under it, have like Bosch. I've left kids in clinic, to sit for 10 minutes so that then when I come back, the Bosch has made things a little bit softer so that then I can, or you can use mild soap and water, but then I can do less scrubbing. And bleeding is a great question and is always very surprising when you see it, but it is expected, it is normal, and we like to see it. Healthy tissue bleeds. So if you see some bleeding that's not abnormal, we hold gentle pressure with like a clean gauze or a clean washcloth until you get it to stop. Sometimes if the bleeding doesn't stop, you can put a little bit of Aquaphor on it and then hold a little more pressure. But it definitely is a normal finding to have some bleeding as you're cleaning.
Okay. Absolutely. If you think about how, the skin on your lips is even so thin, I often tend to think of the face being the same way. So if you have really bad chapped lips, they're crusty, they kind of bleed a little on the easier side, and certainly need just a lot of moisture, which is the same concept here. When we say a lot of moisture, we say at least twice a day to apply the Aquaphor. It could be more. We certainly don't want it caked on the face, but if it looks a little bit dry, we do have to encourage our families to assess for that dryness and maybe put a little bit more on, so the face, when it's moisturized, is looking nice and shiny.
And can you talk a little bit about how to get Bosch to the bedside if you've run out? And also what it smells like, and not to be concerned, because the first time I ever used Bosch on a patient, I smell everything because I'm that nerd. I'm like, what does this smell like? And I was like, oh, this smells like chlorine. Oh, are we sure? So I actually looked it up and found a couple different sources that said it was totally fine, but the smell really took me off guard the first time I used it.
Yeah, Bosch smells like bleach, I think. Chlorine, bleach, along those lines, and that's because it is similar, but it's safe for use on faces and around the eyes, and that's okay. But yes, it is. If you are sensitive or have a good nose, it's definitely surprising and but safe. And then getting Bosch from pharmacy. Yes, you have to have an order for it. It comes from pharmacy. Generally, they send one bottle. It depends on how much you need. I would say I would defer to pharmacy as to how long that will take to get it from pharmacy. But like all medications, you request it, get an order and request it from pharmacy.
Definitely send it home with the families. Also, know that there's another name for Bosch. It's hypochlorous acid. And I think that name could be intimidating. And just want to reassure everyone, it's incredibly gentle and it does a really nice job.
If it gets in the eyes or the mouth, do the parents need to be concerned, or the bedside nurse be concerned?
No, I wouldn't drink it straight from the bottle, but it's not like bleach where you have to be cautious of it getting into anything sensitive. It's made for that reason. And so it is well tolerated when cleaning the face and around and get a little bit in the eyes. It should be okay. We have a few more pieces of information here on like just the dressing changes. I think we've spoken to this a little bit, but I don't know if I can emphasize it enough that the most important part about facial burn care is cleaning before applying more ointment and debris. I think it's kind of my number one pearl when it comes to cleaning facial wounds and getting them that this is my best guess at it, at what it really truly looks like if somebody comes into burn clinic 4 days later and they have never washed it. It looks like this. And then it's really challenging and bleeds a lot more and is very painful for the patient to then do it from there. So if we stay on top of getting the old ointment off and the debris off, then it makes it a lot easier for the patient. But that's my number one. And then sometimes just as information for people to know is that sometimes we do use other ointments other than Aquaphor. So maybe collagenase, which is an enzymatic debrider, or sylvanine sometimes, or sulfamyelin. We use some of those around the face and head if we have a deep, partial, or full thickness burn. So don't be surprised if we're asking for a different ointment from the burn team.
But in most cases with that initial visit to the emergency department, we're probably just going to recommend Aquaphor. And then when we reassess the burn in a few days in clinic, we may switch gears, or when if the patient's admitted, we may switch gears as well.
Exactly.
If the burn dictates that.
So if we have a patient with a large facial burn in the PICU who has a breathing tube and the burn is around the mouth and the forehead, I always like to think worst case scenario. And for me, worst case scenario is a bad facial burn that's intubated and sick in the PICU, because it's like you got all this gunk, everything's gooey, everything's moving around. We don't want it to move around. Like, do you have any hints or tricks about doing burn care to the face under those conditions where things are a bit more tenuous?
My number one, I think, would be, if possible, a nasal endotracheal tube, because it is a little bit more secure, but obviously that depends on the patient and whether or not they can tolerate it. And it's an airway that can have that if they're intubated. I think sedation for critical, in and around an ET tube, making sure that the patient is really well sedated so that they're not going to move around, are probably the biggest ones. And then airways first, right? So we will work around burns if we need to for our airway, and our burn team can come to the bedside to assist with that and make sure that we're all feel like everything is secure and safe. And we can come up with a few different ways to make sure that the ICU team and both the burn team are happy with kind of how we're treating the burns. Sometimes we'll use bandages or like a Methylex AG pad underneath a tape or something like that, but we can kind of work together.
And if could you just remind everybody what the in-house number is for the inpatient nurse practitioner, so they know who to call? Because you guys aren't on the Zebra phones yet, right?
Yes, we are.
Oh, you are. Okay, so
yes,
this
so
is
you
good.
Can search for the trauma burn inpatient provider on the Zebra phones, and the phone number is 602. I think it's 2147. Oh. But now I feel like I'm being quizzed. So if it's 4127 or something like that, I think it's 602-2147. That I believe is the inpatient number. But you can search for it on the Zebra phones. And our previous ASCOM number is 476-8212 and should be forwarded to that Zebra phone.
Okay, that's good to know. Mm-hmm. Yeah, I'll call the number and see who answers and be like, okay,
fairly certain that's what it is. Yeah.
But if they search for, like, they can search burn by name. Yeah. So search for trauma burn. Okay, good to know. Good to know. Yep.
In the emergency department, you can refer families to this brochure. We will have them in the emergency department for all of our patients. It is a trifold, and we have a description about the types of the burns. Specifically, we love this. It's in the middle is changing the dressing, so you can check off recommendations for the family in terms of, and it talks about how to wash your hands beforehand, how to gently clean the burn and pat it dry, and then apply a thin layer of ointment. And you can actually check off again which ointment is recommended. So that's certainly something that we would ask that you send the families, have them refer to. And we also have our video, dressing changes at home, and the link right there. So certainly advise families to take a look at that video, watch it often. It's certainly going to help in those first couple days at home when they're trying to remember all the steps it takes to clean.
And our contact information is on there as well. Our email address, traumaburn@childrensnational.org, is the best way for families to get in touch with us if they have questions about facial care, things like that. If they're overwhelmed or if they've missed the information, they can email us there.
Absolutely. And we're happy to give advice over email, maybe set up a brief telehealth encounter if needed. Triage, the best date for them to come back to clinic. So certainly that we will be in touch with the families if there are any concerns prior to that first clinic visit.
So, do you see families struggling with facial care, or is it not something they struggle with?
I think families definitely struggle with facial burn care, especially if they're not given the right information or all of the information. I find that when facial burns come into clinic and I see them, which generally if they're seen in the emergency department on the first day or two, then they come into clinic somewhere between day 2 and day 4 or 5. I think generally it's an overwhelming visit then. And when they leave, I'm doing a lot of reassuring. And I am very happy to say that often they come back and they're like, it's healed. We did great. We did a great job. They tolerated it well. It got so much better. You're right. Yours was the worst one. Like I'm usually pretty impressed. And I think the families are pretty happy with it after they're at their second visit. Whereas the first emergency department and then their first clinic are overwhelming, but I try and reassure them that it gets better each time, things should be easier kind of each time. But I do think that it's overwhelming, but also well tolerated and gets easier.
Do you have a spiel that you can tell us of what you say to a family in burn clinic to help the families with doing this facial care? So you've already you've done the facial care, they've seen it, and they're probably completely oh my God, she just did a lot. It was not a happy time, but I think that it would be helpful for, everyone to be able to hear what the spiel is so we can remember what to say when we are discharging these kiddos.
Cindy, I feel like I have a spiel for everything. So I certainly do. Of course, I have a spiel for face burns. Okay, let's think about it. I think one of my biggest things that I say to them is that this is probably the hardest visit and facial cleaning you're going to have, right? So I did more than you're going to need to do because generally they come in very crusty and I'm doing a lot of cleaning. So now that I've gotten off all the old ointment, or you weren't cleaning at home because you weren't told to clean at home, or you didn't, or it was scary, or you hadn't, my visit is probably the hardest one, and you can do it at home. Our goal is to keep it moist. So keep it clean and keep it moist. If you're doing the zero form, so if it's covered in zero form, you do it once a day. You just take everything off, clean it a little bit, certainly not as much as I just had to, because usually ours is kind of more involved with something similar to this crust, this dried exudate kind of that you're looking at. And then the rest of it you can do a few times per day if you're using screen time for it, or when they're sleeping, or kind of whatever, a snuggle and read a book and hold wash or soap and water on the face, kind of take a bath if they're allowed to, that I think is what I often tell parents, is that faces heal remarkably well. And I think you're going to be surprised that this was really hard today, but things should get much better. And I wouldn't be surprised if you're healed by the next time you come to me.
What about for that ER discharge? So, because, when a kiddo gets burned initially, there isn't as much yuck. There's pretty
no yuck.
Right. And so
it looks like this, really.
So I bet that a lot a lot of the times you that conversation isn't had because it doesn't look yucky.
Yeah.
So what would you say to a child leaving the emergency department with a facial burn that looks nice and clean and it's nice and red and pink, and you know that, like, we all know that in a couple days it's going to be like this massive, like, gunky, drainy,
Yeah.
smelly. Oh, and we got to talk about smell too, and what's normal and what isn't. But so what do you say to the ER families when they are going home
I
with
would
this new
tell them
injury?
it's you're gonna have to change this tonight, even if it looks great now, but you are going to see some buildup tonight, and that's why we need you to stay on top of it. So basically, really, that anticipatory guidance, it's so important that, you know, that we're not scared of it. Really, the best thing that we can do is be proactive and clean it tonight. You know, the same thing we say with Silvadene dressings. When you take the Silvadene off, it's going to look gross. And, you know, really kind of just describe what they're going to see, and I think they're going to think about that in the back of their minds and say, okay, I think this is okay. But also, you know, in our brochure, we do point out reasons the family should call if the bleeding doesn't stop, if there's a discoloration to the XU date. Again, you know, and we'll make ourselves as available to the families as possible, but really we can't emphasize enough how cleaning it is the best way to heal it.
Yeah, I would add to that all burns drain fluid, and drainage is normal and expected. And especially in the first day or two, you're going to see a lot more drainage, and that drainage is just going to get caught up in either the dressing or the aquaphor ointment. And so that's, you know, it looks beautifully flat and clean and perfect and pink right now, but it's going to get drainage and kind of gunky, and we just want to keep it clean.
Absolutely. I think that second picture, you have the picture of the hand on the top there.
This one
Picture, that's what it's going to look like, I would imagine, you know,
sorry,
8 hours after leaving the ED. Yeah.
You're going to get this film, and if you don't get the film off, then it adds to more and more film and kind of dries out. So this is exactly what it looks like as it starts to like drain, and ointment and skin. And
Yeah, that was very helpful. And then the smell. So Xeroform has its own smell. I'm very into smells.
You're very into smells.
I know.
I was just about to say, you're very
like,
smell.
My olfactory system, whatever, it's very intact. I mean, I can smell anything. So Xeroform has its own smell. And the drainage is going to be kind of gunky and yellow. And a lot of parents are thinking, or I've seen a lot of parents think that it's an infection when it's just the normal gunk and the normal smell. Is there anything that parents and or bedside nurses or could know, like, whoa, this is not normal burn, like, I'm concerned, and to let a member of the burn team know? Is there something that you can, like, distinguish rather from the normal gunk?
I think if you're changing it once or twice a day, then you shouldn't have very strong, like, infectious smells, because it's not a bandage that's stayed on for days. Like, think of that, like, cast that's been on for a while, or like bandage, like that smell. And I would be surprised if someone saw pus coming out of a facial burn, but that would be concerning. And if you're changing something every day, you shouldn't see that. Also, you can think about, once you get the burn clean of the drainage and gunk, as we're kind of calling it, what does it look like then? Like, does it look red beyond the borders of the burn itself? Are there little pimples or pustules? Is there something else that's concerning outside of similar to what we've looked at so far? That would be, like, if you were to see really bright red over here on a burn, that would be concerning.
Rarely do they get infected.
Rarely.
Pretty obvious when they are, as Anne said, surrounding erythema, a potent smell. Sometimes we describe burn dressings that have been in place for some time as almost like a sock. They kind of smell like a dirty sock. So again, that kind of mild odor, you know, not the freshest scent, but if there certainly is a potent malodor, certainly that would be concerning.
That's very helpful. Thank you for all of that. I know it's just like when you see all that like goo coming out and you have that smell, you're like, wait, is this okay or is this
Yeah.
not? But it's good to know that facial burns rarely have infections. So I think that's really good and reassuring to
And-
for all of our listeners and everyone.
And things to look out for again would be overlying rashes, or as Anne said, pimples that have, whitehead pimples. Those certainly would be causes for concern.
And then with face burns, especially when it's in or around the mouth and lips, it's hydration is our number one. So a patient might not have a very large burn, but if it's impactful to being painful for their lips for drinking and they're not maintaining hydration and making normal number of wet diapers, that would be something that would need to come back into us for an NG tube or IV fluids or whatever, for support, for nutritional and hydration support.
So I'm going to ask you both one question as we wrap today up.
Oh, wait, hold on. I have one more slide.
Oh, my goodness. Go ahead.
Sorry. Oh,
well,
we're going to go just briefly mention that it's really important to keep face burns protected from the sun. We generally recommend anything with an SPF of at least 30, and usually zinc or titanium mineral-based sunscreens are better tolerated. And then hat with a UPF in it is really, really helpful. And then I have one about periorbital burns. You don't need an ophthalmology consult if there's a burn around the eye. We've done studies, we've looked into it. The ophthalmology team has agreed with us. If it's generally a periorbital burn, then we use erythromycin ophthalmic ointment 3 times a day around that area, just cleaning with gentle soap and water, like a tear-free soap or Bosch, if that's what you're given or the patient has from the burn team, or if they're inpatient or outpatient. And usually the swelling worsens before it gets better, and it can be surprising and concerning, and eyes can be swollen shut or close to it, and it will, the first day it might be a little bit, but it'll actually get worse before it gets better, but then it goes away with time. And then I think that's my last slide. Yeah.
I think it's also important when we comment on sunscreen and protective measures, as we say, normally these are healed within a relatively short amount of time, seven days, maybe up to 14 days. A lot of families don't think they can take their children outside, and that's really not the case. As long as there is protection, if the fresh air is good, if they need to, do a quick errand, that's okay. We just really want to make sure that the skin is protected, a big flappy hat when everything is healed, that we use a nice sunscreen, and then again, really that's really probably the biggest one of the biggest components of making sure that these heal and continue to heal appropriately, is keeping them protected from secondary damage from the sun.
Yeah, I have a spiel for that too. When people are like, oh no, we're not going outside. I'm like, oh, well, okay. I don't want the 2-year-old to never go outside, right? Like,
Right.
We just want to be safe about it. So definitely protection, sun protection, but not avoidance completely. Let them go to the playground.
One question I've heard a lot is, oh, okay, you said, so my kid can go outside. You said the skin is healed, but can they swim? I've heard that question a lot.
Usually once skin is healed.
Yeah. And healed in our book may not be the conventional image of healing. So when we say something is healed in our book, it is pink and dry, and there's return of epithelial cells. So we say pink, dry, epithelialized, again, equals healed. So the color is not always going to stay that way. It's going to blend in over time. It's going to take a few months. But for that initial clearance for regular activities, i.e. bathing, showering without restriction, swimming without restriction, as long as the skin is pink and dry, again, kind of looks like a skin knee when the scab falls off, that pink shiny skin, then the skin has established itself as its own barrier to infection, and we're good to go.
That actually, with the skin, you lose the melanin. So for darker skinned patients, you will have their normal dark skin with a pink dry area that, we say, oh, that's healed. And families look at us like, oh, that's not healed, because the skin color hasn't come back yet, but it has epithelialized. It can take months, a year for even that pigmentation to gradually normalize, but it will look different, which is another reason why it's not protected from the sun, because it doesn't have that melanin in it to protect it. So it is particularly high risk for getting sunburn, and then can leave a permanent discoloration if it does get sunburned.
I think we kind of like stepped into a really interesting and really good point of like what is healed versus what looks like it's healed. Because if it doesn't look like it did before the injury happened, a lot of us, like as parents and nurses, were like, how can you say that's healed if it doesn't look like it did before? And burns are so tricky. It's not like talking about like the cast analogy. You know, kids break an arm, they put it in a cast, they get it out. The arm may look a little bit smaller, but it's not like nothing sticking out, nothing swollen, you know.
Right.
Both burns, it's so tricky. And I think that's why I think our burn patients are so special. And like they deserve that that extra time with discharge teaching. And that's why we have all of these resources. And yeah, I just think that's such a good point about what it looks like when it's healed.
Yeah.
Absolutely. And also, you know, it's when families come to clinic, especially if we do see that they're having a harder time coping with the injury or, you know, doing the dressing changes at home, we have incredible resources there. We have a dedicated child life therapist, a dedicated psychologist who screens every family to make sure, again, that they're coping okay. And if they need resources, that they are provided, even ongoing therapy in some instances. So again, there's much we can offer to our patients and our families.
Okay, so my two questions. I have one for Liz and one for Anne.
Okay.
And they're both the same question. And since Anne, you've done most of the talking, I'm going to ask Liz first, so then you can think. If there is one take-home point that you want our nurses here at Children's to remember and carry with them, what is the most important for you?
Encourage the families that they can do this. Encourage the families they can do this. And so engage them in teaching early, even if it's, you know, if the parent on day one can't manage to even, you know, be in the room while the care is being done. Maybe the next time the care is being done, they can stand at the edge of the bed, you know, baby steps. Because again, we really have to empower families that, you know, doing this the right way will put them on the right road to healing as quickly as possible. So really getting families involved in the care as quickly as possible, making sure when those videos are ordered on Burn Care through the Get Well network, that families start watching those early, again, so they can really participate in care. And that's a nice bridge to ensuring that they're comfortable with the care at home.
And Anne?
I think take the time to educate and reassure the family. Take the extra 5 to 10 minutes to teach them all of these things that we've focused on, especially the keeping it clean, keeping it moist. If patients go home without that information, or the first time you say it, they kind of miss it because they're overwhelmed, then it really makes a big difference for the patient to be able to tolerate the twice a day cleaning if they're not doing a really big one 4 days later, if they kind of stay on top of it. So taking the time to educate the family and to work with them through their questions. I know it can be a little bit of a setback in our day if we're busy, but taking those extra minutes to really educate the family, I think would be my number one request.
And, in the emergency department, the resources are definitely different than they are inpatient. But teaching is important no matter where you are in the hospital, and having these conversations are important no matter where the child is in the hospital. So in the emergency room, we have created a resource. So if you look on the screen, this is, and do you mind unsharing?
Oh, yes,
so it's a little bit bigger.
Yes, of course.
So we have these little business cards, and I am assuming this is probably backwards since I'm holding, or maybe it isn't. I don't know.
I'm seeing it
No,
right.
it looks right.
Oh, good. It's just backwards for me. Okay, so we have these business cards that have the web link to all of the videos, which are available in the Get Well network if you're inpatient. but we have tons of these cards. All of the social workers in the emergency room has them. And if any staff member wants their own like stack of them, I have them. Come to me and I will give you your own stack. But what's great is on the back of it, there's a QR code. And if you scan even right now, if you're just watching this and you hold your phone up to that QR code, it'll bring you right to the website. And I'm going to share my screen so I can show you all of the videos that we have. So this is just that, this is what the card will bring you to. And if you can see, there's a lot of videos, but the one that we're really talking about a lot today is the at-home dressing change video. So if you click on this, you can see it's 10 minutes long, but that's because we go through 4 different dressing types. But Aquaphor and facial care is in this video. And parents have told us that this has been really helpful. And you can see we have over 100,000 views. So people are using this video. So tell people about it. It takes a second. And if you have one of these cards, I mean, I keep one on my badge. So I can just talk to families and be like, hey, you can just scan it right off my badge. There's lots
extremely
of
helpful. Yeah,
Yeah.
Those are great videos. Yeah.
And a lot of the times, like parents, especially in the emergency department, they're still like blaming themselves that their child got injured. They're thinking like disfigurement and scars and all of these things. Everything that you tell them they may not remember it all. So this is like a great resource that a parent can watch later, kind of when the dust settles.
Yeah.
And hopefully before that first clinic appointment. So, because we hate that first clinic appointment is like a little traumatic for the parents and the child, because it's like, just trying to get all that stuff off. But and I just saw we have 450 likes. That's a lot of engagement for a training video. That's pretty good.
Yes. Well
That's
done.
fun. Well, Liz and Anne, thank you so much for coming and sharing your expertise. And we look forward to doing more of these this year.
Yeah.
And any idea of like what the next topic may be on?
Oh, good question. I don't know.
I don't either.
We'll have to think of
We'll get
something good. Yeah.
Okay. All right. Well, again,